morning, everybody. Hope you guys had a good weekend. Studying for immunizations, I'm sure. So just a couple quick reminders. Thursday, I think, is a recitation again. And we'll also have a quiz, which will be just on today's material. Okay. And then another reminder, I think that Thursday is also the due date at midnight for medical terminology. So many of you have done that. That's great. So just a reminder to those who have not to do that before Thursday so that we can get those scores in. And I think most people are doing pretty well on this last medical terminology quiz. So that's good. All right. So we will be talking about cardiac function today, a lot about heart failure, and a little bit more about valve disease and pericarditis. Okay. I have all the learning objectives up front. I'm not sure why I did it for this lecture this way, but this is your anatomy physiology learning objectives, those for heart failure, those for valvular disorders, and then lastly for pericardial disorders. It looks like a lot, right? But there's only about 60 something slides, so fair amount of detail on some of the slides, but not a ton of slides per se. So we'll probably get done on the earlier side, but definitely won't try and rush through it for any reason, okay? So we'll use that as our outline as well. All right, so you've seen something like this before. This one labeled, I think in the last version we didn't have it quite labeled. But again, as a reminder, if you're not still comfortable with where the blood is flowing throughout the heart, I encourage you to review that and become comfortable. We'll certainly spend a bit more time talking about, trying to figure out how to use this. Okay, that's kind of cool. A little bit big though. We'll spend a little bit of time talking about more emphasis, I guess, on blood flow, particularly through the various valves. Okay? And so I'm going to plug in a different device so that hopefully I can not use the spotlight function on that, but more of a regular pointer. Okay, so as a reminder, we've gone through this before, but it always helps for review. And you've had all of this anatomy previously, but as a reminder, our blood comes into the right atrium through the inferior and superior vena cava, goes through the tricuspid valve, into the right atrium, into the right ventricle, which then contracts and pushes blood out into the pulmonary artery, the left and right pulmonary arteries. And again, everything in blue is deoxygenated. So again, this is our only named artery that is deoxygenated. So these go to the lungs, and then once it goes through the lungs, it returns via the pulmonary veins, which are now oxygenated. And so each of those four veins come back into, kind of goes behind all this, and comes back into the right atrium, goes through the mitral valve, into the left ventricle. Ventricle contracts, pushes blood out through the aorta, and then the whole cycle repeats itself. And then we'll talk about this a little bit more when we get to the valve disorders, but just as a reminder anatomically what these things are. So these are your papillary muscles, which attach to the chordae tendineae, which are responsible for the structural integrity and function of each of the valves. Okay, that are the tricuspid valve over here, and then the mitral valve over here. Okay? So we'll talk about their reports a little bit more when we get to that. So now on a more microscopic level, and this kind of pertains to a lot of contractility sort of issues, our myocardial muscle, okay, is comprised of sarcomeres, which contain very important proteins, actin and myosin, filaments, which are contractile elements. Okay? And importantly, they also need, in order for contraction to properly ensue, is intracellular calcium influx in order for those proteins to properly contract. Okay? So we'll talk about that more when we get to kind of some of our preload concepts again, which we've already talked about a little bit. And then this bottom slide here is really to describe the function of these intercalated discs, which are interspersed between all of those sarcomeres. And that sole purpose is to allow, from an electrical standpoint, the heart to function as a single unit. In other words, the electrical signals that are generated, okay, produces basically instantaneous contraction throughout the two main units of the heart. So the two units that are electrically separated to a certain extent are the atria and then the ventricles. Okay, so the whole heart isn't beating at the same time, isn't contracting at the same time. First the atria contract, then the ventricles contract. So that's a synchronized event. But within the atria, within the ventricles themselves, the electrical conduction is so fast, facilitated by these intracranial discs, that it's an instantaneous, coordinated, synchronized contraction of each of those units. Okay? All right. We're going to use this slide to walk through elements, all of the main cycles of the heart. Okay? So it looks fairly complex, but in reality, kind of once you digest it, it's not. So everything in blue color is representing the systole phase. Everything in the yellow, beige color is the diastole phase. Okay? Again, systole is when we're contracting, diastole when the heart is at rest. Up here is pressure measurements throughout the aorta or the ventricle as identified by the various lines. And then similarly, you get a picture of what those changing volumes are relative to that. We won't talk too much about the EKG. We'll get to that probably. I think we'll start that next week. But if you need a correlation of what's going on, what each of those EKG patterns represent, you can see how they represent according to atrial and ventricular contraction, for example. Okay, so we'll use this slide repetitively to kind of highlight the main parts of the cycle that are occurring. We'll start with isovolumetric contraction. Okay, so we're in this first little small sliver of blue here. Okay, so we're beginning with systole. It's just the easiest place to start. So this is isovolumetric contraction period. What that means is that iso meaning same, volume meaning blood volume of the ventricle is what we're mostly talking about here. It means that that's not changing. Okay. So what's going on here is that during isovolumetric contraction, this is left ventricular contraction, because that's what we talk about when we're talking about systole, talking about the left ventricle. In particular, both ventricles are contracting at the same time, but we focus our attention on the left because that's clinically the most important, physiologically the most important. So as the left ventricle begins to contract, at this point in time, both the aortic and the mitral valves are closed. So it is a closed space. There is no openings for that blood to go, right? And the beginning of that, or the S1 sound, sometimes you'll hear us talk about S1 and S2 sounds. The S1 sound is the sound of the mitral valve closing, okay? And so that occurs as a part of this cycle as well. So what happens is that as the left ventricular begins to contract, it's squeezing down and removing open space from the ventricle, right? And so it's squeezing that. So as a result of that, the pressure inside the ventricle begins to increase as the left ventricle contracts. Does that make sense? Okay, smaller space, same blood volume, it's not going anywhere. That increases the pressure the smaller that space gets through the contraction. Okay? And so that continues until we reach a point such that the pressure on the inside of the ventricle exceeds the pressure of the aorta, forcing the aortic valves to open from a pure pressure difference. Okay? So now we begin the ejection pattern of systole, where the aortic valve is now open because of the left ventricular pressure has increased significantly such that it opens that valve and blood begins to now eject into the aorta from the left ventricle. Okay? At some point, contraction will stop. It's done its maximum contraction of the left ventricle up here at the apex, right? And then it slowly begins to relax. Okay, so the the left ventricle begins to move from the contracted space physiology and now begins to open back up. And accordingly, the pressure will decrease within the left ventricle. Okay? So as that pressure now begins to decrease, as soon as the pressure in the left ventricle now becomes below the aorta, it's going to force the aortic valve closed. Okay? So that's when we get this S2 sound as the aortic valve closes. Okay? So that describes the systolic function. That's what's happening. That's what causes the valves to open, valves to close. Okay. Remember also that we didn't talk too much about the mitral valve, but physiologically, what's also happening is that those papillary muscles in the chordae tender are pulling down on the mitral valve and making sure it doesn't open during systole. Right. We don't want blood to go back into the left atrium, so it's forcing those, forcing that valve to be closed by pulling down and contracting on those papillary muscles. Okay, just put completeness there of what's going on. Now during diastole, we have an isovolumetric period as well, which is this small base over here just after systole has completed. And so here, left ventricle continues to relax, continues to open and expand. The mitral valve and the aortic valves close again, and the atria fills with blood. Okay? So during the diastole phase, atria is filling with blood. As it continues to fill with blood, then the pressure in the left atrium is going to become higher. Right? And then it's going to force the mitral valve to open and then allow blood to enter the ventricular space. Okay? Most of, as you can see by this line here, most of the blood that fills the ventricle from the atrium is passive. In other words, it just does it by gravity. Okay? Just going through the valve. The last portion of the diastolic cycle, there's about 20% of ventricular filling that comes from atrial contraction itself. Okay? So just to have, as we talk about arrhythmias, that becomes important, is that most of it's passive, and a small amount of it typically is via atrial contraction. A lot of times people seem to think it's more fully atrial contraction that pushes the blood into the ventricles. That's not necessarily the case. So when you're at rest, I mean, you're pretty much relying on passive filling. You don't need that 20%, okay? But when you're heavily exerting yourself, that's when you really need that 20% kick of blood filling so that you can increase your cardiac output with more blood, if you will, okay? And so then the left ventricular pressure begins to increase again because the volume is now filling it, and that will eventually close the mitral valve, okay? And then that systolic cycle begins again. Okay, so that's the coordination of blood filling, pressure rising, valves opening and closing. Okay, and that'll come back, particularly when we talk about valvular disorder. So important to understand the cycle, if you will. Okay, so recall that what we talked about before, that cardiac output is a function of heart rate times stroke volume, right? Which is all a component of blood pressure. But specifically cardiac output, heart rate times stroke volume, and usually our kind of resting cardiac output is roughly about 4 to 6 liters per minute, okay, which equates to about a 70 to 100 beats per minute of heart rate, and then an ejection fraction normally of about 55 to 75%. 60-65% is probably your average for most people. And remember what that consists of: ejection fraction. Stroke volume, the amount pumped out by each beat of the heart, divided by how much blood was in the ventricle at the end of diastole just prior to the systolic cycle beginning. Okay, so we call that the left ventricular and diastolic volume. That is the volume of blood that was in the ventricle just prior to contracting. Okay, so that gives you a fraction then of how much blood was, or the ejection fraction of how much blood was pumped out relative to how much it started. Okay? As we'll talk a little bit more when we get to the preload again, it's So this is our resting cardiac output. However, a healthy person can increase their cardiac output significantly based on the need to, exercising, whatever it might be, right? You can increase your cardiac output significantly through a variety of different mechanisms in a healthy person. People with diseased hearts, either the heart failure, myocardial infarction, whatever it might be, may not have this reserve. Okay, so that's why they get much more symptomatic, for example, when they begin exercising, typically, if their heart is not able or it doesn't have that amount of reserve that it normally would in a healthy person. Okay? All right, so what are some of those things that control the ability to increase or decrease heart rate accordingly? A lot of this is review from what we've talked about before, but remember that the heart rate is largely influenced by the sympathetic nervous system, primarily epinephrine, as it interacts and agonizes, stimulates the beta-1 receptor. That increases the heart rate and also increases contractility. Okay? Norepinephrine is released as well, but it's less specific towards the beta receptor. Epinephrine is more specific and has greater activity at the beta receptor. Also what happens controlling the heart rate is the parasympathetic nervous system, and that is via the vagal nerve. And so when stimulated, it will decrease the heart rate. So it's a counterbalance to the sympathetic nervous system. Okay? And that's mediated by acetylcholine. As a reminder, what we get worried about with increased heart rate is that you have decreased diastolic filling time, because heart, you don't have so much time in diastole compared to systole, and so that can lead to decreased cardiac output at higher heart rates. Okay? And again, our stroke volume, as we mentioned before, is affected by preload, which again is our end diastolic volume, in particular left ventricular. Our afterload, which is the resistance to outflow of blood from the left ventricle, and then lastly, contractility. So we'll touch bases on these as it relates to heart failure in the upcoming slides. All right, so this is revisiting preload. And if you haven't heard the term, a lot of times people will refer to this as the Frank-Starling curve or the Frank-Starling mechanism. Obviously, Frank and Starling must have invented this at some point in time in the distant past. But basically what this is, if we go back to the actin and myosin importance of those proteins, we have different levels of interaction of those proteins. Again, these are our contractile proteins, okay? So the way I like to think of it is kind of like, I don't know, maybe it's not a great analogy, but actin and myosin coming together, right, for contraction purposes. If there's not a lot of blood volume, those are very heavily overlapped. So you can see that over here, right? So you don't get a lot of flex. You don't get a lot of power there. But you get a lot more flex and power when they kind of come into an optimal range. But if they get stretched too far, and that stretch is caused by too much blood in the ventricle, you again get kind of a weak contraction. Okay? So they're overstretched over here. What this graph refers to, and for this slide, we only really need to pay attention to one of these graphs. It really doesn't matter which one. But A would be a person that has a healthy heart. B would be some sort of degree of heart failure or compromised contractility. Okay? But what we can see in each of those, we see the same pattern, is that when we have too little blood, okay, which is left end diastolic pressure, we can't measure the actual amount of blood in the ventricle, we can only measure pressure, which then we relate to volume. So when we see left ventricular end diastolic pressure, that's equivalent to left ventricular end diastolic volume. Okay, so you can use those interchangeably from a graph standpoint. Okay, so we have that on the x-axis, cardiac output, or you could also substitute stroke volume there as well to get the same sort of graph. Okay, so we're very low. In other words, we have a more limited amount of blood in the left ventricle, so our preload is low, left ventricular and diastolic volume is low. It contracts, the heart contracts, but it's not optimal, right? Because it's not reached that optimum overlap of actin and myosin. But when we have a normal amount of blood, the heart can increase or decrease cardiac output as it needs to by stretching these actin and myosin filaments accordingly so that it can increase output according to need. So this is kind of where we all want to be in this optimal range. And then when we get too much blood, too much preload, we're over here on the right, actin and myosin get overstretched. They don't contract as efficiently as they should. And so, as you can see, we begin to see that cardiac output or stroke volume begins to plateau or even decrease. In other words, this increased volume normally would increase cardiac output up to a point until it gets overstretched. And then it starts to falter. Okay? So, more blood is good to a point, more volume is good to a point, but at some point for each patient, we begin to plateau out and decrease cardiac output the more blood that's presented to it. Okay? Does that make sense? Or do you want me to go through anything over again on that? Okay. Feel free to raise your hand if we need to. Same graph, but a different concept, if you will. So this is contractility rather than preload. Okay? In preload, we're worried about moving from right to left on this graph according to changes in pressure. For contractility, it's really a vertical move. Okay? In other words, we increase contractility, we're moving from here, cardiac output, at the same actin and myosin sort of interaction, and increasing cardiac output. So we're moving from B to A. That would be an increase in contractility. Okay? And obviously we go from A to B, that would be a decrease in contractility. So it's the force of contraction independent of a change in preload. It's just the inherent contractile function of the heart. So we can increase this, for example, if we get beta-1 stimulation. We said beta-1 stimulation would not only increase the heart rate, but it will increase the force of contraction. So epinephrine is really good. That would move up with epinephrine, for example. But things like hypoxia, infarcted tissue, hypothermia, hypocalcemia, for example, would decrease contractility and move from A to B in that same figure. Okay? So that's what we're talking about when we're talking about contractility. Okay? It's independent of preload, independent of left ventricular and diastolic volume. Okay? So that's touching a little bit more on things we've talked about before. We'll bring all these back into the conversation a little bit. Anything you want me to recover from what we've talked about up to this point? Preload, contractility, anything like that. Okay. All right, so now we're going to switch gears a little bit and talk about how this all relates to heart failure specifically. Okay. So heart failure by definition is a structural functional disorder that causes low cardiac output and or tissue congestion. And that tissue may vary depending on the location. Okay. Common causes, as you might guess, are all cardiac-based for the most part. Hypertension, prolonged hypertension, chronic, I should say. Coronary artery disease, specifically myocardial infarction. Valvular heart disease, which is why we put the valvular disorders at the end of this discussion. And then dilated cardiomyopathy. That's more of an inherited genetic sort of disorder. We're not going to talk about that specifically, but it generally tends to operate along the lines of the concepts of heart failure, so we'll just include it there. Okay. All right, so when we talk about heart failure, there's different ways we can classify that, okay? We can classify it by the type of dysfunction, okay? So systolic or diastolic. And I'm going to use systolic and diastolic because it's a lot easier to say than what we now refer to each of those as. Systolic, heart failure with reduced ejection fraction. Diastolic, heart failure with preserved ejection fraction, okay? Obviously, it's a little bit of a tongue twister, so I'll use systolic and diastolic, but keep in mind, these are the medical terms that it refers to, and these are used in literature and all that, so I'll be familiar with both. So that defines why the patient has a decreased cardiac output, two different types of dysfunction of the heart. Then we can also look at it from where is the dysfunction occurring. For most patients, it tends to be originated on the left side of the heart, but for some patients it might be a little more right-sided based. So we'll talk about what that looks like. This is particularly useful from a signs and symptoms sort of standpoint, less so from a pure management of the patient. Okay? This helps us define how we're going to manage that patient. But the anatomic categorization is more for categorizing signs and symptoms and seeing what's going on. Okay? So as I mentioned, both of these disorders, systolic and diastolic dysfunction, cause a low cardiac output. They just do it from two different separate mechanisms, okay? So for systolic heart failure, it's impaired contractility. Most commonly, myocardial ischemia, infarction, for example. There's limited ability of the left ventricle to contract properly, so therefore it doesn't push out enough stroke volume and your cardiac output falls. Okay? So in that example, typically we define systolic heart failure by an ejection fraction of less than 40%. So in other words, if you have 100 mLs in your left ventricle prior to systole, again this is our left ventricular and diastolic volume for our preload. If we have 100 mLs in there and we eject 30 of it, our ejection fraction is 30%. Okay? So since it's less than 40%, that would be consistent with systolic heart failure. Okay? Conversely, diastolic heart failure is less to do with the contractility properties of the heart muscle, but more with the inability of the heart muscle to fully relax. Okay? So what I mean by that and what that means from a volume pressure sort of standpoint, so if this is our normal ventricle size, if you will, okay? In diastolic heart failure, and this is normal, fully relaxed. In diastolic heart failure, it doesn't fully relax, okay? So the space is smaller, okay? But in this example, we're ejecting 30 mLs in each, okay? So the stroke volume is actually the same, right? But this end diastolic volume is different. Here it's 100 mLs, here it's 60, okay? So you might be saying, well, why doesn't it just keep filling until it gets to 100 mL? Well, what happens is that because of the smaller space, you increase the pressure in the left ventricle faster, forcing the valve, okay, to close and open accordingly. So as soon as you get to that critical pressure, it's going to open the aortic valve in this case. Okay, so in that situation, it's opening or filling when it gets to 60, and then opening the aortic valve because the pressure has been released to kind of open that aortic valve. Versus in a larger space, that doesn't happen. Okay. So you can see then in this kind of numerical example that in each case we have 30 mLs being ejected. So it's not about the stroke volume per se, it's about the fraction that is being ejected. So in this case, because of decreased relaxation of the ventricle, we have decreased left end diastolic volume. So we're going from 100 to 60 mLs in this case. So here we see that the ejection fraction is relatively normal. Okay, so that's consistent with diastolic dysfunction, is having a ejection fraction above 50%. Okay, everybody else is in this in-between category of 41 to 49 is mildly reduced. We won't go there, but just for your information that there is that designation. Okay, so that's inherently the difference between systolic and diastolic dysfunction. One is a full contractility issue. One is a impaired ventricular relaxation, such that it can no longer fill adequately with the correct amount of blood. So it fills with a decreased amount of blood. Okay. Now, with that being said, it is possible, certainly, that patients can have a little bit of both systolic and diastolic dysfunction. Okay. A lot of the diastolic dysfunction is a result of fibrosis that occurs over time. Okay. Commonly associated with hypertension, but a variety of other diseases as well. In addition to left ventricular hypertrophy. Yes?
You said for the diastolic dysfunction that the stroke volume will be the same?
Yep. So, see, in this case, what doesn't, in this example, okay, it doesn't have to be exactly the same, but in this example, stroke volume, what's being pumped out by each beat is 30 mLs. However, the beginning volume in systolic was 100, so it's only pumping out 30%. In the diastolic dysfunction, pumping out 30 mLs, but its beginning was 60. So it's able to eject half of its contents, if you will, right? So defining systolic and diastolic by the ejection fraction is the most common way to numerically divide those. Okay, there's echocardiography, we'll look at other things as well, but that's generally what all of the cardiac studies use to define whether it's systolic or diastolic dysfunction. Okay, does that make sense? So, systolic dysfunction is most commonly caused by ischemia, prolonged ischemia, and/or infarction, a variety of other disorders, including hypertension as well. But we tend to get diastolic dysfunction as a result of hypertension because it increases the afterload, so therefore you build up more cardiac muscle, left ventricular hypertrophy, and there's that chronic state of increased pressure and produces a state of inflammation where fibrosis and tissue stiffness begins to take place, and that is what causes the decreased relaxation portion. Okay? So it's really just realize that, sorry. Okay, so that's how we define systolic versus diastolic, or preserved, reduced ejection fraction and preserved ejection fraction. Again, the most common causes are related here, but now we're talking about what causes left-sided heart failure. In other words, the point of origin of this dysfunction, whether it's diastolic or systolic, is on the left side of the heart. Okay, so this is probably the most common presentation. And again, that's due to contractility issues with the left ventricle, or it could be due to altered blood flow issues going through the aortic or the mitral valves. We'll talk about that at the end of towards the end of the lecture. Right-sided heart failure, the point of origin of dysfunction is on the right side of the heart, so particularly the right ventricle, which can be caused by right ventricular myocardial infarction, for example, cardiomyopathies, same would apply to left-sided as well. You can also get, really in both cases, eventually over time, right-sided heart failure will impact the left side of the heart. Left-sided failure over time will begin to impact the right side of the heart. So they don't become completely isolated. Patients will have signs and symptoms of both, but at least initially they'll probably have one. This also can lead to altered flow of blood through various valves. Pulmonary hypertension in particular is one. We'll talk about that a little bit more as well. Okay, so as I mentioned before, many patients start with one or the other, depending on the site of their dysfunction of the heart, most commonly the left side, but both of them can be impacted over time. So very common for patients to have signs and symptoms of right-sided and left-sided heart failure concurrently. Okay? And so what happens during heart failure is a series of compensatory mechanisms. Okay, and it all comes kind of back to the cardiac output equation and all of those variables that fall into it. So we're going to kind of review many things that we've already talked about, just in a slightly different context. Okay, so to maintain a cardiac output, the body is going to try and adjust heart rate, preload, afterload, contractility, all that sort of thing if it can. Okay, and there's kind of an immediate phase of adaptation, and then there's a chronic phase of adaptation. So all of these mechanisms in particular are very beneficial in the early phase of heart failure, for example, but over long term, they actually end up causing greater cardiac decompensation and furthering heart failure. Okay? So we'll talk about each of these mechanisms of compensation, kind of reiterate some things we've already talked about, but just in the context of heart failure. And again, we're talking about most of this, but it all comes back to making sure we understand that it's not just the heart, right? It's the heart interacting with not only, you won't see it on this slide, but the brain, which is sending signals, right, based on blood pressure, to the vascular system, through the sympathetic nervous system, which also interacts with the angiotensin-aldosterone system, the adrenal gland, and that comes back, and then we have myocardial remodeling effects as well. So it's all very interconnected. You don't have to memorize this graph, but just as you put these things in place, you can kind of see where all of these things are changing for the benefit of cardiac output. Okay? So let's talk about, again, some of these compensatory mechanisms. these hormonal changes, sometimes called neurohormonal changes. And that's the sympathetic nervous system, the renin-angiotensin-aldosterone system, vasopressin or antidiuretic hormone, and then the natriuretic peptides. Okay? So as we mentioned already, we're going to expect then the heart to try and increase cardiac output, one, by increasing heart rate through the beta-1 receptor, increasing the contractility of the heart through the beta-1 receptor. Epinephrine also has beta-2 activity, which actually causes some vasodilation of the arterial system. So that's good in that sense, that it decreases afterload through the beta-2 receptor. Okay? It also has alpha receptor activity as well, which causes vasoconstriction. Okay? So the beta-2 and the alpha are basically working against each other in that sense from the sympathetic nervous system. Okay? This is beneficial, but at the expense of increased oxygen demand. Okay, so keep that in mind. These are good things, but they do cause the heart to work harder, require more oxygen in order to function that way. Okay? Over time, what tends to happen, over more like years, if you will, is that in this sort of situation, the beta-1 receptor in particular can become desensitized. In other words, even though exposed to epinephrine, it's not getting the same effect. The effect is decreased. You're not getting the same amount of heart rate increase or increased contractility. Okay? So we begin to get diminished effects from that compensatory mechanism, but unfortunately, the alpha receptor doesn't have that same desensitization. So you still have potential for epinephrine to increase afterload. Okay? So the heart has to work harder in that situation to get blood out, and is not getting the benefits of beta-1 agonism because of that chronic desensitization of the beta receptors. The renin-angiotensin system we talked about before, so a lot of reminder stuff here. Again, angiotensin 2 being a very potent vasoconstrictor, also stimulating aldosterone production to promote water sodium retention to increase blood volume, so it's an attempt to increase preload, right? It also does interact with the other systems, causing an increase in norepinephrine release, inhibiting its uptake so that there's more epinephrine available. Also is a indirect stimulus for more vasopressin release to promote more water reabsorption from the kidney. And then all of these, angiotensin 2, aldosterone, for example, also have influence on the pro-inflammatory cytokine production, as well as fibroblasts and collagen formation, and those are important from a cardiac remodeling standpoint, kind of the long-term effects of these initial benefit compensatory mechanisms. Okay, so aldosterone will be released as a result of all this. Also has fibroblasts, collagen formation, fibrotic sort of process. And then again, vasopressin or antidiuretic hormone will be released. It does have some vasoconstricting activities. It's usually fairly short term, not something that's going to be long term. But its main purpose of being released is, again, to increase that water retention from the kidney. And all of these things are one to increase blood pressure, increase contractility, increase preload. It's trying to move from the left to the right on that Frank-Starling curve so that we can get increased cardiac output by increasing the preload. Okay. The natriuretic peptides are produced in a sense to counterbalance those things that we just talked about. Okay? They are released when the ventricles and atria get stretched too much. Okay? So they perceive that they have too much volume, and so they release these atrial and brain natriuretic peptides to counteract that. So what they do is then interact with the kidney and tell the kidney to get rid of more water and get rid of more sodium. Okay, so that's hence the term natriuretic peptides. That means getting rid of sodium and water. Okay, so these counterbalance basically the renin-angiotensin system, if you will. So these are upregulated during heart failure. Okay, we'll circle back to some of the lab stuff that we monitor. And then again, back to the Frank-Starling curve or the Frank-Starling mechanism. Many of the things that we talked about already, increasing contractility, increasing renin-angiotensin system, for example, all in an attempt to increase the preload, is meant to augment cardiac output. Again, it's done at the cost of oxygen demand and potentially impacted by the ability to supply that. Okay? So this is the Frank Starling curve again, just a slightly different version. Again, we have cardiac output here on the y-axis and our preload basically on the x-axis, which is again left ventricular end-diastolic pressure, but we'll interpret that as a volume. Okay? So normally we have this steep increase when we get increased volume, increased preload, we'll have this steep increase in cardiac output. But as we get to different degrees of heart failure, compensated heart failure, decompensated heart failure, cardiogenic shock, just different levels of severity, okay? The heart has a more limited ability to try and compensate, okay? So as we move our preload, increase our left ventricular volume to the right, increasing preload, we begin to have, we look at the decompensated, minimal benefit on cardiac output because it doesn't have the capability to do that. So if we keep adding volume, keep adding preload, even through the renin-angiotensin system, for example, we're not going to get a huge increase in cardiac output. And as we begin to plateau and actually decrease, if this line were to go further, that's where we start to get a lot of our congestion. Okay, because we have too much blood in the system, too much volume in the system, and our heart cannot increase cardiac output effectively to compensate for that. Okay? The more long-term effects, all of that is good initially. It's trying to preserve heart function and cardiac output. But over time, what happens is the left ventricle begins to change structure. A lot of it due to interstitial fibrosis, for example. We'll talk about the types of remodeling on the next slide. But basically, again, as a function of aldosterone and angiotensin II, for example, it stimulates these fibroblasts to produce more collagen or more fibrotic process, which leads to more ventricular wall stiffness and inability to function properly. Okay? In addition to the myocyte loss that we get due to infarction, for example. Okay? And so what happens from a structural remodeling standpoint, this is normal, symmetric. This is a picture of a slice of the left ventricle, if you will. Okay, so the bottom part is the left ventricle. So this is normal. And this is what would be called concentric remodeling. Okay? So this would be similar to what we'd expect for a patient that is very chronically high afterload, chronic high hypertension. Okay? The left ventricle has to build more muscle in order to pump that blood out. So you see this thickening of the left ventricle wall thickness. Okay? So that's that sort of remodeling. This would be very consistent with what you expect to see with left ventricular hypertrophy. In patients that chronically have too much volume overload as their main source of cardiac dysfunction, in other words, their preload is just chronically high, in order to decrease that pressure in the ventricle, it's going to dilate. Okay? So the tissue begins to thin out and dilate that chamber so that the pressures can be low. Okay? So that is eccentric type of remodeling. Okay? So now as we begin to talk about what are the signs and symptoms, okay, it's important to recognize where blood goes, where it's prevented from going, and where it goes when there's too much blood. Okay? So back to kind of this general blood flow scheme, do you remember where there are no valves preventing blood flow from going forward or back? Where does that occur in the system? Anybody know?
Arteries.
More in the heart itself, sorry.
Oh.
You're right, arteries do not have like a valve system, veins do, but more within the heart itself. Okay? So keep in mind as we talk about signs and symptoms a little bit, that blood coming in from the vena cava system into the right atrium is not controlled by a valve. Okay, it just comes in. Okay, so that means if you get overloaded on the right side, fluid's going to back up into the venous system. Okay? On the left side, okay, if we get volume overloaded here, say in the left ventricle, okay, that's going to go back through the, eventually back through the right atrium and then into the pulmonary vein, okay, which goes right to the lungs, right? There's no valve from the pulmonary veins into the right into the left ventricle, sorry, just as there's no valves from the vena cava coming in to the right atrium, okay? So that blood coming back into the right and left atria has no valves, okay? So blood can back up in either of those systems when it's not moving forward, okay? So that causes kind of a distinct signs and symptoms sort of profile, whether the patient has predominantly left-sided heart failure or predominantly right-sided heart failure, okay? We have left-sided, again, here's our left ventricle, okay? If blood is not moving forward adequately, right? So we have decreased cardiac output from the left side, where's that blood going to go? Well, it's going to back up into the left atrium for one, but that's pretty small space. Then it's going to back up into the pulmonary veins and eventually back up into the lungs. Okay? That can continue backing up, but we just kind of stop at that point. So your signs and symptoms of left-sided heart failure include pulmonary congestion because of that fluid backing up into the lung. Okay? Which can then interfere with gas exchange at the alveolar level, cause edema within the pulmonary circulation. We'll show you what that looks like. Okay? And because of the decreased cardiac output coming from the left ventricle, whether it's systolic or diastolic in nature, you have decreased cardiac output. That means that you're not providing as much oxygen and energy to the rest of your tissue, right? So you'll tend to have effects from that. Decreased tissue perfusion, lethargy, all that sort of stuff. We'll see that on another slide. On the right side, if you have predominantly right-sided heart failure, well, where's that going to back up first? Into the right atrium, and then back into the vena cava system. So your entire venous system is then suspect for accumulating a lot of blood because it's not moving forward. Okay? So you get these signs and symptoms here. We'll talk about this a little bit. All right, so general decreased cardiac output, particularly from the left side, okay? Decreased perfusion, fatigue, weakness, mental status changes because of decreased perfusion, oxygenation of the brain. Could impact renal function if the blood flow is significant enough. Cyanosis if it's not getting enough oxygen. Okay? Reflex tachycardia, trying to compensate for that, you would expect to see, unless they happen to be on a drug that blocks that effect. Right-sided heart failure, right? Fluid retention. It's going to occur in the venous system because that's where it immediately backs up. There's no valve to prevent it from backing up from the right atrium into the venous system. So we'll show you pictures of what this looks like. So the entire venous system can be impacted. So tissue edema, typically we'll see that in the lower extremities, and that occurs in the venous system just because of gravity, right? So you'll tend to see more fluid accumulation in the lower extremities because of the increased volume of blood, increased pressure in the venous system. You can also see that transmitted to the abdominal cavity, so you can have some distended abdomen because of ascites, which is fluid accumulation in the peritoneal space. It's just that distension and fullness can kind of alter their GI system as well. JVD, jugular venous distension. So again, more directly, blood backing up into the venous system, increased volume within your venous system. You can see that in your jugular vein very easily. I'll show you a picture of that. Or if you press on your liver, that forces more blood up to the brain, right? And so you can elicit that jugular reflex that way as well. So you'll see those terms as we're looking for. We might get some volume dilution causing hyponatremia, and typically one reason we ask patients who have heart failure weigh themselves daily, okay? Because that weight is always going to be due to volume changes, not due to changes in muscle on a day-to-day basis. So if you start to see pounds adding up over a couple of days, you're retaining too much water, you might have too much volume, you might put yourself into decompensated heart failure because your heart can't keep up with the volume that's being presented on a preload sample, okay? So this is what some of those things would look like. So this is jugular venous distension. Normally you should not be able to see that. That implies that the veins are full of blood, right? It's not being moved from the right side of the heart to the left side of the heart. Tissue edema, sometimes referred to at varying degrees of pitting edema. So this is usually more on kind of the lower extremities. You can see the higher the number of pitting edema, the greater amount that occurs, such that if you press on leg tissue itself, it stays there for 1 to 2 minutes and doesn't rebound. And that means that there's a lot of fluid in the interstitial space because it's being moved out of the venous space because of that increased pressure. Okay, so pitting edema would be very common from a right-sided heart failure standpoint. Similar concept with the pulmonary congestion. This would be predominantly that's related to left-sided heart failure. So as that blood backs up to the right, to the left, atrium, and then it backs up into the pulmonary vein, and then it backs up into the lungs, okay, because the lungs are just a huge reservoir of vasculature, right? So it can accommodate a lot. But as that pressure builds up, basically you go from this kind of normal situation such that there's so much pressure here that the fluid begins to leak out of the capillaries. It leaks out into the pulmonary interstitium, and that causes pulmonary edema. It causes fluid to accumulate in your alveolar cells. Remember that your alveolar cells are where the gas exchange occurs. And so if your alveolar cells are full of fluid, there's not going to be any gas exchange there. Okay? So pulmonary edema has the potential to alter oxygen and carbon dioxide exchange. The worse it becomes. Okay? So again, all that backup fluid goes into the lungs and begins to alter lung function, unfortunately. Okay, so we can see pulmonary congestion in different ways, obviously on an x-ray, which I'll show you on the next slide, but we can see different manifestations of that. Okay? Dyspnea at rest, shortness of breath at rest. Okay, feel like you can't catch your breath. Dyspnea when laying down, that's called orthopnea. That's because all the fluid when you lay down is going more towards your heart and your chest, right? It's not being influenced by gravity at that point. So orthopnea is dyspnea when you're laying down. Paroxysmal nocturnal dyspnea is, as the term suggests, nocturnal, being at night. People that have sudden onset of dyspnea at night. And that's due to an imbalance of the sympathetic and parasympathetic nervous systems. At night, your parasympathetic is more active. What tends to happen is you tend to get more bronchoconstriction. In other words, your airways narrow. And so that can sometimes precipitate dyspnea in those patients when the parasympathetic nervous system is overactive relative to the sympathetic nervous system. So they'll wake up short of breath. Okay? You'll commonly see people that have significant orthopnea. That's where they may sleep on 2 or 3 pillows to elevate themselves, right? So they can try to take advantage of gravity so that there's less fluid accumulating in their lungs. Wet cough, very common as well. Wheezing and crackles when they're listening to your lungs, that just means that there's fluid in there, and they can hear that fluid when you're breathing in and out. Okay, so that's consistent with heart failure. Many other things can cause that, but consistent with heart failure. And if it's impeding the ability of the alveoli to exchange oxygen and carbon dioxide, we'll see those changes in the labs as well. This is what pulmonary edema might look like. Okay, so on the left side, this is, you can see all of the good portion of the pulmonary tissue is grayed out or white out here, for example, but then after 24 hours after getting aggressive diuretic therapy, in other words, we're forcing them to get rid of fluid to the kidney, you can see that clears out fairly significantly. Heart is still pretty enlarged here, but you can see the clearance from a pulmonary edema standpoint. Okay, so that's what we hope to see when we're giving diuretic therapy. That patients then can get rid of that pulmonary edema and begin to oxygenate properly. Many of the fibrotic changes that occur chronically over time do place these patients at risk for arrhythmias or even sudden cardiac death because those fibrotic changes change how electrical signals go through the heart. Okay, so that predisposes them to a variety of arrhythmias, but also including those that cause sudden cardiac death. So that's just another manifestation that we have to kind of keep in back of our mind. Okay, we'll finish up the next couple slides and then take a break. Okay, so the diagnosis obviously is made by signs and symptoms that the patient is presenting with. May or may not be related to a recent heart attack, for example, so that we can make sure we know their past medical history and the risk factors of other cardiac diseases that may predispose them to heart failure. And then commonly we'll look at BNP, or the brain natriuretic peptide. And we talk about that being elevated in patients with heart failure because it's trying to get rid of more volume, get rid of more sodium to try and counterbalance the renin-angiotensin system, for example. Okay? So we see elevated concentrations of that when we're in heart failure. So typically anything above 500, it's pretty likely that it may have heart failure. It's not purely accurately diagnostic just for heart failure, but it's likely given the situation that may occur. But if you suspect they have heart failure and their BNP is less than 100, it's probably due to something else, such as mimicking those signs and symptoms. So we can use BNP as somewhat of a predictive factor, if you will, easy to get, right? So do know those low and those high cutoffs just for diagnostic purposes. We'll certainly get an echocardiography to look at the ejection fraction and decide whether they're in systolic or diastolic, or maybe a little bit of both. Pulmonary edema, or checks our X-ray to look for any evidence of pulmonary edema, blood gases to see if there's any oxygen exchange issues, but also the X-ray can give you a sense of cardiac size as well. So this would be an example of cardiomegaly. The heart is very large compared, should be much smaller relative to the diameter of the chest cavity. Okay? This is not a complete list of all medications. There's a lot of new medications. This gives you an idea where they work in heart failure. Okay? Vascular resistance, okay? The increased afterload. ACEs and ARBs by decreasing the angiotensin II. Same with the vascular junction, okay? Renin-angiotensin system, aldosterone antagonists. We're trying to prevent the vasoconstriction from angiotensin II. We're trying to prevent the aldosterone for trying to replace the blood volume, because that can be problematic, right? So we're trying to decrease the water retention for real aldosterone antagonists. We use diuretics to get rid of that excess volume to make sure our preload isn't too far to the right. On the Frank Starling curve, we want to move it more to the middle. Beta blockers can be used to impact mostly the sympathetic reflexes. Okay, and then we can use agents such as digoxin, Vlvdis, which are pro-contractility agents. They increase the contractility of the heart so that we can increase the function. Some newer agents that are not on this graph, but things like Jardiance can be used. Where you typically see Jardiance from an advertisement standpoint, what's it used for? Diabetes, right? But it also has a secondary role in heart failure because what does it do? Does anybody know what Jardiance does, just as a basic mechanism of action? How does it treat diabetes? It helps the kidney get rid of glucose. It helps the kidney get rid of sodium, both at the same time. So in a sense, it helps you get rid of fluid in that sense. So there's a lot of other new agents coming on board that take advantage of similar concepts just through different mechanisms. Okay? And these are all kind of the mechanisms that I talked about verbally on the last slide, but you can kind of put them together as far as how these drugs interact with heart failure, how they might benefit heart failure in different mechanisms. Okay? So I'll let you read that on your own. I'm not going to ask you drugs or what they do necessarily. That's just for your information. Okay? So why don't we take a break, and then we'll come back with the last 20 or so slides with valve disorders, and then we'll talk about cardiac disorders. Okay? So any questions? I know that's a lot. I'm happy to repeat anything here, or if you have office visits you want to do, that's absolutely fine. So we'll take a 10-minute break, so we'll start again at about 8 after.
I seen your email. I didn't get a chance to reply, but 12:20, is that good?
Yeah, something like that, because it's a 10-minute quiz for makeup, so they should be done by that.
Okay, cool.
Does that work?
Yep, that's fine. Did you want to do on Zoom, or did you want me to come to the office?
Yeah, I don't do any kind of quiz or
okay.
interviews via Zoom.
Perfect.
So yeah, come to the office.
Okay, cool. Thank you.
Thank you.
Sorry. to interrupt you again.
No, no problem.
I'm still confused on why the stroke volume for the diastolic would be the same, because isn't the stroke volume affected by contractility? So,
But contractility is not changing for diastolic.
right.
Right.
So then for systolic, then why is it? So this example, they're saying stroke volume for both is 30.
Both low, but just for different reasons.
But why is it the same?
Because in one, the systolic dysfunction,
Right.
the stroke volume is 30, which is low for both of them, right? The stroke volume is 30
Right.
because the heart the left ventricle can't
contract.
properly.
Right.
So maybe it has an area of dead tissue and it doesn't participate in the contraction, so the force of the contraction is lower.
Right.
So it's only pushing out 30 instead of 60, for
Right.
example.
Okay.
Okay. The diastolic dysfunction doesn't necessarily have a contractility issue.
Right.
So it can still expel
So it can still
50%
contract
of its blood,
30 milliliters.
or more. I mean, that's just an example. But its cardiac output is decreased because it's not allowed to fill with the adequate amount of volume because the ventricle is not relaxing fully. So the volume that it starts with is a lot lower. So, for example, if you could fix the diastolic dysfunction and say restore it to, instead of filling with 60 mLs back to 100, its ejection fraction would be normal. You would have an ejection fraction of probably 60-70%, right? So your stroke volume would go up in that case. So it's just two different etiologies of why the cardiac output is low. In each of those situations, the cardiac output is low, just from a stroke volume standpoint. Okay, because the cardiac output, stroke volume times heart rate, assume the heart rate's the same in each of those situations, the cardiac output would be exactly the same in both of those situations, just two different mechanisms of why the cardiac output is low.
Okay, gotcha. And then we could talk about this one in our office hours. Well, after we go over the exam, because it's more complicated.
Which one is that?
This part we was talking about. Yeah, I got confused. We went too fast.
No
Right, we could go back to that. Okay. Thank you.
Sure. Hey. Yeah, anytime there's assessment, she has to do one of those. Yeah, she's been fine. I knew you mentioned that before, but I didn't know where. But yeah, she would be the one. We can set everything up like right now, she was that's the only place that yeah, so Monday was
You're one of those? You're one of those covers?
Dude, I was doing no, hold on.
Right, to get back last sector and not with a goal. That's the last.
No, because I got a notification from them saying it was delayed. It was right? It was delayed. Oh no, and then it was under when you it's not one I was like, I didn't know that one like September or whatever, I was like, that's not true. Guess what? It was that 2024. That's like, oh wait, hold on, this is 2024. Alright, then I'll listen. So they had
No, Loki thought they were the same thing.
what do you mean?
Pretty happy. Like, I look at the date, I'm like, you picked this up last month. It's just oh, wait, sometimes they don't pick it up for like months, so it's like you look bad.
But that's the thing, like, they put it under consideration and they're like, you know, like, cancel my conference order, we can get it online. It's always
She was in the work here.
Okay, why don't we get started again? We'll get you out on time, a little bit earlier. So now we're going to talk about valve disorders, which can be heavily related to mimicking or even causing heart failure. Typically they're related. So, as we mentioned before, there are 4 valves, okay? What we call semilunar, mostly based on their shape, kind of half-moon shaped, are the aortic and pulmonary valves. So again, aortic, left ventricle pumping out to the aorta, pulmonary valve, right ventricle pumping out into the pulmonary artery, okay? And then what's called the atrioventricular, just by name, that means that they're in between the atria and the ventricle chambers, right? So those are easy to remember. And on the left side is the mitral valve, on the right side is the tricuspid. Not that there's not important disorders associated with the right-sided valves, there certainly are, but for our purposes and focus, we're just going to focus on those valves that are on the left side, so that being the mitral valve and then the aortic valve. Okay, so they tend to have a lot more clinical manifestations related to them, but just keep in mind that similar things can happen on the right side of the heart as well. Okay, so valve disorders are typically caused by a variety of different things. Just over time, they can become calcified, heavily fibrosed, such that they don't open and close very well. Chordae tendineae rupture could be due to a myocardial infarction, for example. So they're not opening and closing via those muscles, and the tendon itself is ruptured. Could be an infection of the valve, endocarditis, genetic malformations, or just due to prolonged heart disease that changes the geometry of how those valves interact with the capillary muscles, for example. So, for example, if the tissue here doesn't contract very well anymore, it opens the door for valve disorders such as regurgitation, things of that nature. Okay? So, just a general etiology of what could be involved. When we talk about the various valve dysfunctions, stenosis and regurgitation are by far the most common prolapse. I'll mention what that is, but we won't talk about any further. So stenosis is a disorder of valve opening. Okay? And so what you can see here in item B in this figure is that those valves should be completely open, okay? But they're partially open. That creates a restriction of blood flow, an obstruction to blood flow, right? So the opening is inappropriately narrow in this case, okay? In A, that would be more consistent with regurgitation. That is a disorder of the valves properly closing, in other words, preventing blood from going somewhere. You can see in this situation, they don't fully close. There is a little bit of space there, so now blood can trickle back to where it's not supposed to be. That's what regurgitation is. Prolapse is really kind of an exaggerated regurgitation, if you will. This is where you would have significant disorders relative to chordae tendineae or the capillary muscles, preventing those valves from normally staying closed. But if they're weak, the pressure when the ventricle contracts, for example, might force them to go into the atria. So the mitral valve, for example, we're using that as an example. They normally should be closed, right? But if they prolapse, they're going into the atria because of the increased pressure. So it's kind of an exaggerated regurgitation, if you will. So the net effect of all of this is that it alters how blood flows through those chambers. Okay, that blood flow becomes not normal. Because of inappropriate opening or inappropriate closing of those valves, that creates turbulent blood flow. Okay? So when your physician or whoever it might be, providers, listening to your heart at different things, they're listening for murmurs. Okay? They're listening for signs of turbulent blood flow that may be a sign that you have mitral or aortic valve disease, for example. Okay? So they're listening for those sounds created by that turbulence. We're going to use this slide as we go through each of these disorders. But just to orient you a little bit, here we have stenosis kind of on the left side, regurgitation on the right side, and they're divided into whether it's considered a diastolic or a systolic murmur. And that really is defined by what part of the cardiac cycle is that valve disorder occurring. Okay? So here, you'll hear a systolic murmur for aortic valve stenosis and mitral regurgitation. For mitral stenosis and aortic regurgitation, that's a diastolic disorder, or a diastolic murmur. Okay? Hopefully that'll become a little bit more apparent as to why when we go through each of these. Okay? So first is aortic stenosis. Okay? And so, as you can see, what happens is blood flow through the aortic valve. The valve isn't opening as it normally should, so that creates resistance to blood flow and restricts blood flow, okay? Which then causes hypertrophy of the left ventricle as a compensatory mechanism. So just as we talked about the arteries being vasoconstricted, causing increased resistance and causing increased afterload, this also increases afterload because it's a fixed obstruction coming out of the in the entry to the aorta that restricts blood flow and creates a lot of resistance to outflow. So when it's severe, you can get left ventricular hypertrophy as well because it's trying to compensate and overcome that obstruction. Okay, and that's all again due to afterload. Okay. So as this progresses over time, where that opening becomes less and less open, if you will begin to see a decrease in cardiac output, and it's fixed. It can't change. So no matter what the compensatory mechanisms of the sympathetic nervous system might be to increase cardiac output, it's only got this small opening to get through. So it doesn't really change with exertion, for example. When people exert themselves, they will tend to be very symptomatic because they can't increase our cardiac output because the amount of blood that's coming out of the left ventricle in the aorta is a fixed amount because of that stenosis. Okay? So you may precipitate angina or chest pain in many of these patients because, again, it's the amount of blood coming out into the aorta that fills the coronary arteries, right? So if you have less blood coming out, you have less perfusion of the coronary system. Less cardiac output to the brain can lead to faintness and syncope, for example, passing out, precipitate heart failure. And because this is occurring during systole, in other words, contraction opens that valve, forces blood out, that's a systolic murmur. Okay? We look at mitral stenosis on the other side of the heart, or on in between the atrium and the ventricle, I should say. Right? So this is impaired opening of the mitral valve. So normally during diastole, blood should be filling from the atria to the left ventricle, right? But the opening is much smaller now. So it doesn't fill the ventricle nearly as rapidly. So more of the blood gets retained in the atrium. So you can see here, compared to this last one, a little bit, that the left atrium tends to become enlarged because it's engorged with more blood, because more of that blood, less of that blood is going from the atrium to the ventricle. Okay, so that increases left atrial size and left atrial pressure. Okay, and so again, produces symptoms similar to with decreased cardiac output because less ventricle filling, so less diastolic filling, less preload, and so that impacts the ability of the heart to keep up with its needs. So all of that blood can, again, if it's building up within the left atrium, can then back its way through the pulmonary veins and back into the lungs, causing pulmonary congestion, okay, and eventually causing right-sided heart failure as well. Anytime you get any sort of situation, and in this case is a good example, that causes chronic enlargement, expansion of the left atrial space, they become very prone to certain types of arrhythmias. So atrial arrhythmias, such as atrial fibrillation, become very common. We'll talk about that next week. Okay? But since this occurs during diastole, when the filling phase of the heart, this is a murmur that you will hear during the diastolic phase, and therefore it's called the diastolic murmur. Aortic regurgitation, so in other words, now we have blood coming back where it's not supposed to come back from. Okay? So normally what we have is we have, during diastole, blood filling the left ventricle from the atrium, left atrium normally, that's our normal process. But now, because the aortic valve isn't properly closing, it's allowing blood that was pumped out into the aorta to come trickling back in. Okay? So what that does is then it increases significantly the left ventricular volume because it's not only getting its normal supply from the atrium, but now it's getting kind of a resupply from blood that's pumped out into the aorta, trickling back through this leaky valve. Okay? So that increases left ventricular and diastolic volume significantly. Initially, Frank-Starling curve will increase cardiac output to take care of that, but eventually over time, this is where you're going to see that left ventricular dilation, that thinning of the remodeling that causes the thinning of the ventricle wall. Okay? Again, all of that can then lead to signs and symptoms of heart failure because you're not getting as much blood pumped out through the aorta, too much of it is coming back into the left ventricle. Okay? So again, that occurs during diastole, during the filling phase, so that's a diastolic murmur. And then lastly, mitral regurgitation. Okay? This is where we have blood going across from the ventricle into the atrium when it's supposed to be closed. Okay? So this occurs during systole. Okay? So normally this valve should be closed, allowing blood only to pump out through the aorta, as it normally should. But because this mitral valve is leaky, it's allowing blood to go back up and into the atrium. Okay? So you can see some left atrial enlargement there as well. Okay? Now that we have extra blood volume over there, sometimes that comes down to the left ventricle as well. But overall, again, decreasing cardiac output because blood is going into the atrium and not out into the aorta as it normally should. Okay? All right, so that's kind of a summary of the main types of valvular disorders that you might run into. And there's lots of patients that have them. And this is how they might impact or exacerbate heart failure signs and symptoms as well. Okay? All right, so now lastly, we'll talk a little bit about pericardial disorders and the various types. So first is pericarditis, which is basically an inflammation of the pericardial space. So normally we have an inner and outer lining, which is called the pericardium. Okay, and in between that, there's a little space which is normally filled with a small amount, 30 to 50 mLs roughly of pericardial fluid. That's normal, right? And what that does is help the heart expand and contract without significant friction, right? So those pericardial sacs allow that expansion and contraction of the heart. Although that can be inflamed, and that causes pericarditis. We can also see an increased amount of fluid accumulation within that space. And so normally, instead of 30 to 50 mLs, we might now have 100, maybe 200 mLs, for example, that occupies that space. And that begins to constrict down the ability of the heart to expand and contract normally, right? So it decreases that space. So that's a pericardial effusion. And then in the worst case scenario, that effusion may cause what we call a cardiac tamponade, such that the amount of that effusion is so significant that it significantly impairs the ability to have the left ventricle pump upward. We'll talk about that in a minute. Okay, so those are the main disorders that we'll talk about. Pericarditis typically is fairly self-limiting, may last just a couple weeks, if that, and is most commonly due to a virus. Virus or echovirus are the most common. Okay, so make sure you know that it's typically a viral infection, which for the most part we just wait out. Treat it symptomatically, and then hopefully it goes away. But there can be other causes as well. I'm not going to ask you anything on this list, but understand that it could be bacterial, it could be due to a variety of different diseases, different conditions that may occur over time. Okay, so you definitely start with viral infection and see if that tests positive first. Okay. What happens during acute pericarditis is that the pericardium becomes inflamed into a virus or infection, whatever it might be, and that allows protein to enter that pericardial space that's not normally there. And some of the proteins that enter that is fibrin. Remember, fibrin is a growth coagulant sort of mediator, right? So when everything resolves from the acute pericarditis standpoint, the fluid leaves, gets reabsorbed back into the rest of the body, but it leaves all those proteins behind, including fibrin. And so they can form scar tissue that normally isn't there between the inner and the outer pericardial sac. Okay? And so that can cause pain when it's contracting and relaxing because of those adhesions that have occurred. Okay? And it can become significant such that it doesn't expand and contract as it normally does, impacting the function of the heart. So that's restricted pericarditis. Okay? But that's, at least in part, what causes some of the pain when you get pericarditis is that those two layers, the inner and outer pericardial sac, normally just slide over each other with no resistance whatsoever. Now they're connected with fibrotic scar tissue. So that expansion and relaxation doesn't occur as it normally does, but does so with a little bit of pain as well. So this typically causes a certain set of signs and symptoms that would be consistent with pericarditis. Okay, so typically sharp, abrupt onset, again caused by a viral disease, for example. It does cause chest pain, so it's very easy to confuse with a myocardial infarction, for example. Okay, it does have some radiation to the neck, arm, and shoulders, which is also could be confused with myocardial infarction. But it does tend to occur more. The pain tends to be cyclical, such that when you inhale, inspire, or cough, that the pain is worse. And the reason for that is when you inspire, you increase ventricular filling. And increasing ventricular filling expands the heart, expands the interaction between those two pericardial spaces. Okay, forces them to rub against each other a little bit more. You'll typically find that people will naturally find resolution a little bit by leaning forward. It reduces some of that pressure on the pericardium, and that helps relieve some of their pain. So if you find patients in chest pain and they tend to sit and lean forward, that could be an indication that they have a pericarditis, and that's their way of relieving some of that pain. The other cardinal symptom, when I say cardinal symptoms, they call them that because when you see this, you have to think of this disease. Doesn't mean it's the only thing that can cause this, but you have to think of this disease. Okay, so it's very consistent with pericarditis, for example. So the next cardinal symptom is a pericardial friction rub. So when they're listening to your lungs expand and contract, okay, they can hear, your heart expand and contract, they can hear the rubbing of those visceral pericardial sac layers rubbing together. Normally, again, it's very frictionless, but when you have pericardial inflammation, you can begin to hear the movement of those layers across each other. So it appears as you hear it as a kind of a high-pitched sort of scratching sound. Okay, so that's what they're listening for. You can see ST segment elevation changes, for example, as well. So again, that's also consistent with the myocardial infarction. So again, none of these are highly specific towards one or the other. We just have to put the symptoms together. You expect to see a little bit of evidence of inflammation because of bacterial or viral disease, for example. You might see CRP, which is C-reactive protein, which is a general inflammatory mediator of the body. That might be elevated as well, but they're not specific. Okay? You might just see that, but it's not specific towards this disease, for example. So typically, again, a lot of these are viral, so they'll just go away over time. So you treat them symptomatically. Maybe just non-steroidal anti-inflammatory agents, or maybe corticosteroids to decrease the inflammatory response. But nothing long-term, typically. Okay. Now, if we move on to pericardial effusion, this is where we get more fluid in that pericardial space than should be there. Normally, there is some to help promote that kind of frictionless movement between the pericardial spaces. Okay. It could typically occur as a manifestation of anything that causes pericarditis. It could also be related to cancer. For example, you have malignant cells that are producing a lot of fluid, and it goes into the pericardial space. Less common than a viral infection, thankfully. And the presentation really depends on how much volume occupies that space and how fast that volume accumulates in that space. Okay? So, for example, you can have a very large volume of effusion that occupies the pericardial space, but if it accumulates over a very long period of time, the heart has the ability to adapt to that. Okay? It can make changes and function somewhat normally and be relatively asymptomatic. But if you have a rapid accumulation of that fluid, it may only be a much smaller volume that causes significant cardiac compromise. Okay? So here, if we have 200 mLs that accumulate slowly, it allows for adaptation, pericardial stretch, may not be symptomatic at all. But if that 200 mLs comes in very quickly, like over minutes to hours, the heart doesn't have the ability to adapt to that, right? So those patients become significantly ill and could then cause cardiac tamponade, which can be life-threatening, and this is what it looks like. Okay? So normally, in our normal cardiac cycle here, our volumes are fairly equal. But what happens during cardiac tamponade, as you get more fluid accumulating surrounding the heart, means it can't expand and contract as it normally does, right? So it's decreasing the space. So when you breathe in, you increase filling of the right atrium, and what that ends up doing is then pushing, that volume pushes against the left ventricle, which can't expand as it normally does, and so your left ventricle becomes very small, and therefore you lose a significant amount of cardiac output because of that. Okay, so typically what will happen then is because of those increased pressures, it forces the septum over and decreases the space of the left ventricle. And that decreases the cardiac output significantly, such that they might not be able to survive unless there's quick intervention. Okay? So typically, again, what we'll see with cardiac tamponade is severe hypotension because of decreased stroke volume, not enough contraction going on in the left ventricle because of that pressure differentiation. Tachycardia is trying to compensate. Usually what we'll see in that is what we call pulsus paradoxus. And so that's when we inspire, we increase venous return, right? So we get right ventricular filling, the right atrium filling, and then the right ventricular filling, which then pushes that septum over. And cardiac output decreases during inspiration because of that. So when you're taking a pulse at the same time during inspiration, the pulse will weaken because cardiac output is decreasing during inspiration. And as you expire, the pulse intensity will increase again because you're relieving that pressure on the left ventricle again. Okay? Typically we'll hear, because all the volume in there, pulmonary edema, shortness of breath, muffled heart sounds. Normally they're fairly crisp because there's so much volume in the heart that tend to be a little bit more muffled, so that's very characteristic of tamponade as well. And then lastly, just from a treatment standpoint, the only way to really treat cardiac tamponade is to stick a needle in that pericardial space and drain as much fluid as you can so that you relieve the pressure on the ventricles so that they can begin to expand and accommodate the blood as they normally would. Okay? So that is everything that I wanted to present. I'm happy to recover anything you want, or if you need time to digest it, which I completely understand. I definitely make office hours and I can re-explain anything that you want to. But I'm here for questions if you want. Otherwise, you guys are free to go.